Good morning. My name is Stephanie Taylor. I'm a professor of medicine at Wake Forest School of Medicine, Atrium Health in Charlotte, North Carolina. And I'm going to talk today about post-sepsis syndrome and support for sepsis survivors. So we'll divide the talk into two parts. First, we'll talk about some adverse outcomes that are frequently experienced by sepsis survivors, and then we'll shift to talk a little bit about how health systems can put care delivery practices in place to support sepsis survivors, particularly in the transition out of the hospital and as they continue on their recovery. So there are multiple lectures within the series, largely on improving outcomes for sepsis. So I'm sure you've heard a lot about the large impact that sepsis has from a public health standpoint. One of the most common conditions causing hospitalization and high rates of hospital mortality. Although those rates of hospital mortality have improved over the past decades with increasing attention to early identification and rapid administration of antibiotics to appropriate patients, those type of things have really improved mortality and sepsis over the last few decades. The result of that, though, is that we have an enormous population of sepsis survivors. So patients who survived that initial infectious event and survived to discharge out of the hospital, but are often still left with persistent health challenges that we'll talk about in a minute. In the United States, that number is around 1.4 million patients who survive sepsis each year, and globally, it's really a huge population of patients that draws public health attention. I love this conceptual model drawn up by Hallie Prescott and Derek Angus, describing sort of the trajectory that a patient goes through in a sepsis event. So the nadir of the episode is the hospitalization for sepsis. And then that part that we had talked about that we are getting better at, the resolution of the acute illness, which we're getting better at. And patients do tend to resolve that infection with the good care that we provide. But what really has not been a key focus of understanding in sepsis until more recently is this final period, the recovery. We had tend to thought of sepsis as a very acute illness, and then once that infection is better, once the cytokines are quelled, patients are fine. But what we're learning is that this recovery trajectory is very different for different types of patients. So some patients will go on to recover completely and approach the health status that they had prior to the sepsis event. Some patients, unfortunately, will continue to experience persistent impairments long after the sepsis episode is resolved. And some patients will continue to decline in their health, experience further deterioration, and ultimately succumb to consequences of that sepsis event. And so we're reconceptualizing how we think of sepsis as not so much an acute illness, but as a somewhat of a chronic condition where people accumulate morbidity after the initial event. And just a reminder that just surviving sepsis really does not mean that patients have restored quality of life necessarily. And we'll talk individually about some of these symptoms, but patients often acquire new deficits in their physical function, cognitive impairment, mental health challenges. They have trouble returning to work and social roles and have high rates of readmission and mortality after discharge. So this is a study, one of the kind of the first studies that started to show these post-sepsis sequelae forming what some people call the post-sepsis syndrome. And this was by Jacka-Washina in 2010. This was a study that connected Medicare data with U.S. health and retirement patient-reported outcomes. And they found that the rate of cognitive impairment, moderate or severe cognitive impairment, increased from about 6% at baseline prior to sepsis to about 16.7% after a sepsis event. So this increase in cognitive impairment following a sepsis event. We mentioned functional disability after sepsis, and this is a really big deal. This is something that matters a lot to patients, and cognitive impairment as well. But in this analysis in that same study, the investigators found that sepsis survivors gained, on average, two new functional limitations, so two new impairments in their activities of daily living after an episode of sepsis. And importantly, this occurred in patients who prior to sepsis had no limitations, and they developed two new functional limitations. So we're talking about a big change for patients brought on by an episode of sepsis. Mental health or psychological challenges we have become increasingly aware of in the post-COVID era, but this was demonstrated several years ago after sepsis. On the left, you see depression scores. On the right, you see post-traumatic stress disorder scores. But again, high rates of both of these conditions and anxiety as well following an episode of sepsis. All of these things kind of contribute to outcomes that we measure for our patients from a health system standpoint. And sepsis represents one of the most common causes of hospital readmission. Estimates vary depending on populations that are studied, but about 1 in 3 patients with sepsis gets readmitted to the hospital within 90 days. And that makes sepsis one of the most common, if not the most common, cause of hospital readmission compared to some other common conditions that we track readmission rates for and really are concerned about reducing. It's also a very expensive cause of hospital readmission. And so an important question when we talk about high readmission rates is, to what extent are readmissions after sepsis preventable? This was a really kind of elegant way to address this question. Hallie Prescott and her colleagues evaluated readmissions after sepsis, and they looked at the reason for readmission, so the diagnosis associated with the readmission, and categorized those reasons according to whether or not they were an ambulatory care sensitive condition. And that's a designation of conditions that are presumably, if the condition had been detected and treated in the ambulatory sector, that early pickup and early treatment would have prevented a readmission. So in this study, almost half, 42% of readmissions after sepsis were due to conditions that were categorized as ambulatory care sensitive. This was in some way this great opportunity that if we could address these problems that patients were having after discharge, after sepsis, that we could potentially reduce that very high readmission rate. In addition to readmission, patients after sepsis experience increased risk of mortality that persists for quite some time after discharge. This study in a Medicare population found that more than 1 in 5 older patients after sepsis experienced mortality up to 2 years after sepsis. And more than half of these deaths were thought to be attributable directly to the sepsis event. Same thing in a somewhat younger population, followed for 5 years. Again, a persistent elevation in mortality after experiencing sepsis that lasted for up to 5 years in this population. So we've done a lot of work describing and identifying these adverse outcomes that sepsis survivors experience even after they've resolved their acute infection and been discharged from the hospital. So how do we address those? How do we begin to improve these outcomes for sepsis survivors? Certainly, I think we need to continue all of the really great work that is being done on early sepsis management, so early detection, or administration of appropriate antimicrobials, source control, hemodynamic stability, those type of things. We need to continue to do a really, really good job on that to improve long-term outcomes. We're also starting to learn more about how to treat patients in the hospital or in the ICU with an eye towards recovery. So things like early mobility, preventing delirium and treating it when it's there, engaging families, those type of things that help patients have better long-term outcomes that we can do while they're in the hospital. But what is sort of been identified as a black box, things we didn't really understand until more recently, is what kind of care and how do we provide care to patients after they're discharged from the hospital. We're in this kind of resource limited state for hospital acute care, where as soon as a patient is basically off pressors and lactates down and they're up and around, it's time for them to be discharged. But we all know that they aren't recovered at that point, and they still have multiple things that are going on that need to be addressed. And so, how do we operationalize the care that we provide to patients after sepsis discharge? One thing to think about when we're talking about providing care to sepsis survivors is the amount of post-acute care and support that patients need, and heterogeneity in the way that they receive the support. So in this study and other studies are fairly similar, about a third of patients after sepsis get discharged home with home health. 6% of them go to acute rehab, about a quarter of them go to skilled nursing facility, and about 5% go to a long-term acute care hospital. So a lot of heterogeneity in where patients are going and types of care they're receiving, which can make it challenging to provide post-sepsis care in a standardized way. But we know that we need to improve the way that we provide post-sepsis care. These are results of a online survey of sepsis survivors and their family. It really highlighted how far we needed to improve the transition care we are providing to sepsis survivors. So across multiple different categories of hospital services after discharge, sepsis survivors and their families consistently rated that they either did not receive post-discharge services or they were somewhat to very dissatisfied with those services. Kind of in response to this knowledge gap on how to care for survivors after sepsis, experts in the field, Hallie Prescott and Derek Angus, put together this review calling out some sort of evidence-informed practices that we should be doing for patients after a sepsis hospitalization. And these were these four things: screening for common and treatable impairments, really close attention to medication management, anticipating and mitigating risk for common causes of health deterioration, and evaluating goals of care and addressing goals of care for patients after sepsis. Some of our observational work, we looked retrospectively at patients in our healthcare system at Atrium Health to determine how consistently those four elements of care were being applied for patients after sepsis, and whether those things were related to outcomes. And we found that these things were not being consistently applied, ranging from 10 to 11% to 50, 60% delivery of those care elements. But what was really fascinating was that the more of these care elements that survivors received, the lower their odds were for readmission and mortality at 90 days. This was sort of in a dose-dependent fashion, that the more elements you got, the lower your odds were. And it was really pretty striking effect size if we could deliver those care elements. So we have the signal that we know what to do for patients. We at least have some guidance on care delivery that needs to occur. But how do we operationalize as health systems that type of support to make sure that it gets delivered for survivors? One option is kind of using channels that are already in place. And this study and some ongoing work from investigators at the University of Pennsylvania evaluated the importance of home health and physician follow-up after sepsis discharge. And so in this study, this was a retrospective analysis of sepsis patients who were receiving home health after discharge. And they found that patients who received early nursing visits within 48 hours and an early physician follow-up, if they had both of those things, they had a lower risk for 30-day hospital readmission. It couldn't be one or the other. It had to be both. And so kind of figuring out how to prioritize patients for early follow-up and ensuring that patients get these early follow-ups, both from a home health nursing visit and the patient's physician, I think is an important strategy for improving outcomes. Second is something that's really kind of gained more attention in the post-COVID world, and that is a follow-up clinic. So these are usually branded as post-ICU follow-up clinics. Um, but we can sort of extrapolate their benefit to sepsis survivors because many patients in post-ICU clinics are sepsis survivors. And this is a really appealing care delivery model for survivors of sepsis because it provides the opportunity for patients to come into the clinic, be seen by a multidisciplinary team of professionals that can address the multiple types of challenges that patients are facing. The problem with ICU follow-up clinics really is that there are kind of known barriers to implementation of this type of care. And these barriers have been really elegantly described through some really nice qualitative work by Kim Haynes and her colleagues that described these barriers to ICU clinics. And if you've tried to do a post-COVID clinic or a post-ICU clinic, you're probably very familiar with these. So lack of funding, lack of physical space, how to identify patients that are appropriate for the clinic. And really the big one, and this bears out in all of these types of studies, is attendance, patient and family attendance in the clinic. So these studies and these operationally, people find that no-show rates are really high. Patients just aren't getting to the clinic. There's a variety of reasons why that's the case, but it's really a big barrier for demonstrating the effectiveness of these type of care delivery models. So what our group did, sort of to overcome those challenges of the brick and mortar ICU clinic, and bring in kind of the best of all these different care models, was we developed a sepsis transition and recovery program, a STAR program that's a virtual program delivered by nurse navigators that really delivers these multiple components of post-sepsis care to patients. Largely via the telephone. So it's low technology, it's easy for them to access. And the way it works is patients are identified in the hospital as high risk for readmission or mortality after sepsis. Our nurse navigators make contact with them while they're in the hospital, follow along, help make sure best practices are being done. They help prepare them for hospital discharge. They make contact with patients after discharge within 48 hours, following that research that a home health visit or some type of visit like that within 48 hours is important. They review medications, check on symptoms, assess physical function, provide support, kind of overcome any barriers patients have to getting the right care. And then the navigators make regular contact with patients at regular intervals through 30 days or 90 days, depending on the version of the program. And they just provide support for sepsis survivors, targeted support throughout that transition period. We evaluated the effectiveness of this program in a randomized controlled trial, the IMPACTS trial. So we randomized about 700 patients from 3 hospitals in North Carolina to either receive support from the STAR Nurse Navigator program or usual transition care. And what we found was really encouraging that patients receiving support from the STAR program had about 5% reduced odds of experiencing the composite of rehospitalization or mortality at 30 days. And later on, as we got more follow-up data, we wondered whether these benefits of this program were sustained beyond the duration of the program participation. So in the IMPACTS trial, the STAR program was delivered for 30 days. And we evaluated 30-day outcomes. But to what extent does the program create sort of sustained benefit or really alter the recovery trajectory for patients? So we evaluated 12-month outcomes after the program. And again, really encouraging results for the 12-month outcomes. In the STAR program, there was about a 7.2% reduction in the rate of readmission and hospitalization, readmission or hospitalization at 12 months. So a sustained reduction in those adverse events that lasted for a whole year after the program or after a hospital discharge. So really some encouraging results. The work we're doing now is related to understanding what components of the program are really effective and understanding what factors are important to for successful implementation of this program and a variety of different contexts. So to summarize, there's an increasing number of sepsis survivors due to both the increasing incidence of sepsis and all the great work we're doing in helping patients survive to hospital discharge. These survivors unfortunately face multiple challenges after hospital discharge. Optimal care models for delivering transitions care are sort of in their infancy, being developed and studied. It's a really exciting time for this type of work. Our work evaluating a multi-component nurse navigator program to support sepsis survivors has been effective in reducing both 30-day and 12-month readmission and mortality. And then I'll just emphasize the importance of post-illness care in terms of capitalizing on these gains that we've made in hospital mortality and early treatment. We need to also make sure that we're supporting patients' recovery so that they can not only survive, but survive to a health status and a quality of life that they are happy with. Thank you very much. I was honored to be able to present this today.